Welcome to The Explainer. Today, we're doing something a little different. We're going to step right into the high-pressure world of a surgical viva exam. In this simulation, I'll be playing the role of the examiner, and I'll also be your guide, walking you through the absolute best in-class responses.
So take a deep breath, focus up. You are the candidate, and your consultant exam starts right now. The whole goal here is to show a safe, systematic approach to a patient who is critically injured. Every single word counts.
So here's our game plan. We're going to follow this case right from the moment the patient hits the door, all the way through resuscitation, the big surgery, and what happens after. Let's get started.
All right, candidate, settle in and listen very carefully to the scenario. So there it is. The scene is set. A young guy, a penetrating injury to the abdomen. The clock is already ticking. Now, this very first question is going to set the tone for the entire exam, so let's see how the perfect candidate would handle it.
Okay, let's get into the initial assessment. This is where you have to show that you're grounded in the fundamental principles of trauma long before you get lost in the specifics of the injury itself.
How would you approach this patient? Now, this is such a classic opening question. See, the examiner isn't looking for a diagnosis yet. They're testing your process. If you give a scattered, disorganized answer here, that's a huge red flag right from the start. I would approach this patient using the Structured Advanced Trauma Life Support, or ATLS protocol. My immediate priority is the primary survey, A, B, C, D, E. I'd be assessing for and managing any life-threatening injuries simultaneously. And folks, that is the only correct answer. It shows you're a safe, systematic doctor who isn't going to panic.
Very good. You perform your primary survey. Here are your findings. Okay, now look closely, because this slide tells a whole story. Just look at circulation. A blood pressure of 80/45 with a heart rate of 110, that is screaming hemorrhagic shock. This guy is bleeding out and fast. Then look at disability. A GCS, that's the Glasgow Coma Scale, of 8 is absolutely critical. That means his brain isn't getting enough blood and he can't protect his own airway. And finally, exposure. A rigid abdomen is a classic sign of internal bleeding, and that weak pulse in his leg, that's a massive clue that a major artery has been hit.
All right, you found the things that are going to kill this patient. Now you have to fix them. This next part is all about turning those findings into immediate, life-saving actions.
What are your immediate priorities now? You hear that? This question is all about prioritizing under extreme pressure. The candidate needs to rattle off several things that have to happen all at once.
My immediate actions are: 1. Activate the trauma code blue to get the whole team here. 2. With a GCS of 8, I'm going to intubate and ventilate to protect his airway. At the same time, my team will secure 2 large-bore IV lines, draw blood for cross-match and baselines, and start a rapid fluid resuscitation with 1 liter of warmed crystalloid. And finally, we'll apply direct pressure to the wound.
Okay, let's step out of character for a second, because this is a huge exam tip. Notice how a real marking sheet from the source gives you points for every single one of these actions. In a viva, you can't just say, "I'll resuscitate him." You have to spell it out step by step. That's how you get all the points.
While we're resuscitating, I'd also order the trauma series of x-rays, that's chest, abdomen, and pelvis, to look for other injuries. I'd get an arterial blood gas because I'm fully expecting a severe metabolic acidosis from the shock. I'd also insert a Foley's catheter to track his urine output, a great sign of kidney perfusion, and give him prophylactic antibiotics and a tetanus shot for that penetrating injury.
You've initiated these actions. However, after the fluid, the patient is still unstable. His blood pressure is 80/55, the abdominal x-ray shows free gas, and his hemoglobin comes back at 7.2. And this right here is the moment of truth. Your initial resuscitation is failing. He's what we call a non-responder. This is the pivot point where your whole strategy has to change dramatically.
So, we've hit a critical juncture. This patient is actively dying on you. Trying to do more resuscitation in the ER is just wasting precious time. A decision has to be made, and it has to be made now.
How does this change your management plan? The examiner is looking for one thing here: decisiveness. There is only one right answer. Any hesitation, or worse, suggesting more imaging like a CT scan, that would be a critical failing error. Given the ongoing instability and the free gas on X-ray, this patient needs an operation immediately. I would activate the massive transfusion protocol, starting with O-negative blood right away. My definitive next step is to take the patient straight to the operating room for a laparotomy. I would also urgently page the vascular surgery team and let everyone know our plan is for a damage control surgery.
Let's just pause on this concept of damage control surgery because it's a total game changer. For years, surgeons would try to fix everything in one go, but patients would die on the table from what we call the lethal triad. They'd get too cold, their blood would stop clotting, and their system would fill with acid. Damage control flips that on its head. The new philosophy is get in, stop the major bleeding, stop any gut spillage, and get out fast. It's about putting the fire out first. The fancy repairs can wait.
So now we're in the operating room. The lights are bright, the pressure is on. The candidate has to show they don't just know when to operate, but they know how to do it.
You're in the operating room. Outline the key principles of your damage control surgery. Again, the examiner is listening for a structured, logical sequence. No rambling, just the core steps.
The procedure follows 4 key principles. First, a big midline laparotomy incision, from top to bottom for maximum exposure. Second, control the major hemorrhage. We'll pack all 4 quadrants of the abdomen to stop the bleeding temporarily, then find the source. Third, control contamination, like quickly stapling off a hole in the bowel. And fourth, a temporary abdominal closure, often with a vacuum device, so we don't cause a dangerous pressure buildup inside.
Excellent. During the operation, a simple sigmoid colon injury is found and quickly repaired. The vascular surgeon controls the major vessel bleeding. There is significant pelvic venous bleeding, which you control by tightly packing the pelvis. The abdomen is temporarily closed. And you can see those principles playing out right here. The bowel injury was simple, so it got a quick fix. The big vessel needed a specialist. And that messy pelvic bleeding, just pack it and get out. Defer the complex stuff for later.
The surgery is over, but don't get comfortable. The patient is nowhere near out of the woods. In fact, for damage control, the most critical phase has just begun. The fight now moves from the OR to the intensive care unit.
The patient's abdomen is temporarily closed. What is the plan for the next 24 to 48 hours? You see, this question checks if the candidate understands the whole journey. It's not just about the surgery, it's about the entire arc of care.
The next step is to get the patient straight to the ICU for aggressive resuscitation. Our main goals there are to reverse that lethal triad we talked about. We need to actively warm him up, fix his clotting problems with blood products, and correct the acidosis. Once he is stable, we'll plan to go back to the operating room for a second-look laparotomy, usually in about 24 to 48 hours, to take out the packs and do the definitive repairs. And so, our simulation comes to an end. The candidate has navigated the most dangerous part, but that final question, it really lingers, doesn't it? The initial fire, the hemorrhage is out, but now you have new enemies waiting in the ICU. Things like abdominal compartment syndrome from all the fluids we pumped in, sepsis from the contamination, and multi-organ failure from the shock. It just goes to show you, managing a major trauma isn't a single event, it's a continuous battle. And anticipating the next threat, well, that's the real mark of an expert.